So next up, I'm excited to introduce Dr. Elaine Nsoesie. She's an assistant professor of global health at Boston University. She is also a BU Data Science Faculty Fellow as part of the BU Data Science Initiative here at the Hariri Institute for Computing. Dr. Nsoesie aims to use digital data and machine learning to improve population health. She applies data science methodologies to global health problems, particularly in the realm of surveillance of chronic and infectious diseases. She completed her PhD in computational epidemiology from the Genetics, Bioinformatics, and Computational Biology program at Virginia Tech. She also has an MS in statistics and a BS in mathematics. She's published extensively in epidemiology and public health journals. She has also written for NPR, The Conversation, and Quartz. Dr. Nsoesie was born and raised in Cameroon. Happy to welcome you.
Hello. So I'm going to talk to you about how we're using machine learning, specifically applied to digital data, for public health. So most of the work I do falls into the field of digital epidemiology. And what we're mostly interested in is using data that's not collected specifically for public health purposes, but applying that data to public health problems. So these includes text, image, video, sound, location data, biological data, etc. So these are just examples of some of the kinds of information that we would be interested in from social media, for example. Does this work? So an example here is someone tracking their weight on social media. That could be useful if you're looking at information about how people use social media for tracking health behaviors. Another example over here is someone talking about having an upset stomach. That could also be informational if you're trying to track a specific condition, health condition on social media. You also have an example over there of someone talking about the flu shot. That could also be useful if you're looking at sentiment about vaccines to see how people think about vaccines and whether people are likely to take vaccines or not in different communities. So as I mentioned, this data comes from many different sources. Social media is one of those. So we get data from Facebook and Twitter. We also get data from expert mail and discussion websites. So these are discussion websites where people talk about things like medications or specific diseases. They talk about side effects of medications. That could be really useful. We also get data from internet searches, so from places like Google. We have data from health apps and crowdsourcing, news reports. So there is a surveillance website called Health Map that basically mines information about outbreaks globally and puts that on a map, so you can go on that website and see what outbreaks are actually happening in your neighborhood. And then we also get short messaging, information, etc. So in my work specifically, these are some of the sources that I've looked at. I've gotten data from Baidu, for example. So Baidu is basically the Google of China, and we were interested in looking at flu in China. And we wanted to see whether what people were searching in China could be useful for estimating flu in China at the national level. So we looked at searches for specific symptoms, but also specific strains of influenza in China. Another example of a data source we used is Yelp. So when you go to a restaurant and you eat and you get food poisoning and you get really angry and you go to Yelp and write a review, we mine that data, and we work with local departments of health to inform them about what's happening in their communities. So if a lot of people suddenly say, I went to this restaurant and I got sick, they can get that information and do some kind of targeted restaurant inspection. Or it could be an outbreak surveillance, and they can actually go and investigate and stop outbreaks before the spread. Twitter, we've used Twitter a lot for different studies, from looking at how we can do influenza surveillance at a community level and also at the national level. We've looked at how patients talk about their health on Twitter and whether that could be informative. We've looked at how people talk about physical activity, food on Twitter, just some examples. As you can tell what this is, I was poisoned. It's basically people complaining about food poisoning. So this is a crowdsourced website. Anyone can go on it and report about food poisoning. So the interesting thing about foodborne illness is that you can get infected, but then don't see symptoms until 1 day or 2 days later. So you can blame the wrong location, because you assume that's the location that made you sick. So it's very challenging to do surveillance. So what we usually look for is a group of people reporting about having symptoms about the same time. So if you go out to eat in a group and you all got sick, that's an indication that you all got sick at the same place. We've also looked at Amazon data, specifically looking at customer reviews. So when people talk about products, if you bought a food product from Amazon and you wrote a review about it, we look at that data to see if we can use it to predict whether a product is going to be recalled or not. So if a lot of people were complaining about mislabeling, which is a really big issue for people that have allergic reactions to certain products, we look at that information and see whether it could be useful. And then there's Flu Near You, which is a crowdsourced surveillance website. If you sign up for Flu Near You, you basically get an email every week asking you if you have flu-like symptoms. We've used that data to see how it tracks with reports from the CDC. So there are lots of other examples. I'm going to talk a little bit more about satellite images work later on, and Twitter work as well. So I decided to choose one topic to focus on, and this is obesity. Obesity is a major problem globally. It affects millions of people. It's been associated with over 3.4 million deaths globally. So it's a very important problem in global health. And there are many factors that have been linked to obesity. These include biological factors, but also includes environmental factors as well. And in the US, obesity affects about 1/3 of the adult population. So there are two other sources that we've looked at to study obesity prevalence in the US. One is social media data, and the interest here is looking at behavioral risk factors. So how do people talk about physical activity? Are they actually interested in physical activity? And how do people talk about foods? Are people eating healthy or unhealthy foods? And the good thing about social media data is that if you actually have geotag data, you can get it down to the community level, so you can actually look at specific community characteristics and how that differs across the country. So I just wanted to show an example of what Twitter data looks like. I'm sure most of you have been on Twitter and you know how this data looks like, but that's a tweet, and you get information like the Twitter handle, the date and time of the tweet, user profile picture, etc. So there's information that's very explicit about the user. There's information that's very explicit about the tweet. But then you can also extract additional information based on what people have provided. So this could be things like the disease state. So if someone said, I've had cough for 3 days, you can infer that from the data. You can also get things like gender, using people's usernames or how they present themselves on social media, their networks, etc. You have a lot of other demographic information that you can infer from social media, and this data can be really useful for public health purposes if you're looking at specific populations, to study specific populations and look at how disease spread maybe differs across those populations. It's also important for our work because we think about who is actually being captured in this data. Just because the data is big doesn't mean that everyone is represented. So we try to see what are the demographics of people that are actually posting this information, and why does that matter in public health? Because we don't want to only represent people who have more money, higher education, and already have access to these resources. We want to make sure that we're capturing people that also have highest disease burden, who also tend to be people of the lowest socioeconomic status. So let's talk more about food. So this is just an example of the kind of information that we'll look for. So someone posted about cooking a particular meal, and they actually mentioned that meal or a particular food item. So we can extract that information. We also gathered information on physical activity. So people will post about going out for a jog, or going hiking, or doing CrossFit, or yoga. So many different things. And this data can inform us in several different ways. So there's what we put online, and then there's what we're actually revealing about ourselves that we don't always think about. So for example, posting or your search history could tell someone about your occupation, or event sharing. What kinds of events you share on social media could also be indicative of your income. So what kind of people do you hang out with? And so we've harvested some of this information to get information about demographics on social media. So on Twitter, when you sign up for an account, you're not always asked for demographic information. Well, you're not asked for demographic information in general. On Facebook, you might be asked for specific demographic information. So Facebook has a lot more data about demographics than Twitter does. But you can also infer certain information about demographics using just the information that people post on their profile. So things like their usernames or their actual names. So we actually used that and looked at 3 different methods and then brought those 3 methods together using a logistic regression classification system, an ensemble system, and then came up with a final input. So for every single user that's included in our data, we want to know if we would classify them as male or female. And the information we use is something like their names. So we try to match their names to social security data and use that to infer classification of gender. And then we also look at different ways, so for people who don't have their names, we look at their usernames and see if we can also use that information to infer gender. So after we get gender, we separate our data into 2 different classes, and then start looking at what kinds of exercises do people talking about on social media, and how does this differ across regions in the US. So what we find is that everyone is walking. So everyone talks about walking. And then if you start looking at males versus female, males tend to talk a lot more about CrossFit compared to females. This also differs by region, so there's some regions where there's a lot more discussion about specific physical activities for males, and then you see the opposite for females, and so forth. So there's so many factors that can, influence how people exercise. It could be how your friends are exercising, or it could just be what kind of exercises is your community interested in. So all of those are factors that can influence you. Another thing we're interested in is looking at calories consumed. So this is based on the foods that people reported. We went back to the USDA and got an estimate of calories for each of those different foods, and then estimated these separately for males and females for all the counties in each state, and then just visualized this to see the differences. And we were very surprised at how significantly different this was for some states. So you have males below and females at the top for most of the different states, except for Mississippi, which we're still trying to figure out why. But in most cases, men tend to talk about lower caloric foods on social media, or Twitter specifically, while women tend to talk about higher caloric foods. And we think one of the reasons is that, women when they're on a diet and they end up having a cheeseburger, for example, they would tweet about it and say, I feel so bad, I had a cheeseburger today. Or when we go out to brunch, we would tweet about it. And sometimes those foods tend to be higher caloric foods than maybe we're consuming on a daily basis. The last thing we looked at was calories burned. So this is based on, linking back to the exercise, what kinds of exercises were people reporting. So, and this is very important because data from the CDC shows that women tend to not meet the recommendation for exercises compared to men. And that's kind of what we're seeing in terms of the kind of physical activities that women are reporting. They tend to be lower intensity exercises compared to men. Then we put this data together in a regression model and try to see if we could estimate obesity using this data, in addition to environmental covariates, so things like access to physical activity spaces, crime rates for different counties, things like that. And basically what we get is, right here is the data we're getting from the CDC, and then this is what our model is trying to estimate. And the gray areas are areas where we don't have data. And so we do those separately for males and females. And what we found is that there is a very strong correlation in what our models are able to estimate using social media data in addition to environmental data, but there's still just using social media data by itself is not good enough. So the second study I'll talk about looks at satellite images. And we published this last year, and the idea was to see whether we can use deep learning to examine the built environment, and then try to see how that correlates with adult obesity prevalence in neighborhoods in the US. And there's been quite a lot of work in this area already, looking at how environmental factors are linked to obesity. So people have done things looking like the density of fast food restaurants and how that links to obesity, access to parks and how that correlates with obesity prevalence, green spaces around neighborhoods, etc. But the thing is, for most of these studies, the way things are measured and the tools that are used in measurement tend to be different. And so you have one study done in the same city that would look at density of fast food restaurants and say this is very highly correlated with obesity. And then another study comes and basically looks at the same thing and says this is not very highly correlated with obesity. So trying to think about, is there a way that we can apply the tools that we have and come up with a more comprehensive measure of the built environment that then can be used across cities that would allow for comparison. So we got data for 6 different cities: Memphis, Tennessee, Seattle, Bellevue, Tacoma in Washington, San Antonio, and Los Angeles. So the numbers that you see are rankings in terms of obesity prevalence. So California is the 47th most obese state in the US, while Texas is the 8th most obese state in the US. So we wanted to get states that have really high obesity prevalence and states that have really low obesity prevalence to see if our results will be consistent across. And then we got estimates of obesity prevalence from the CDC for validation. And another thing we wanted to compare to also was points of interest. So looking at the density of different things in neighborhoods, density of fast food restaurants, density of grocery stores, density of police stations, which was quite interesting, density of other things that are just in that environment. And then we look at income as well and how that, because we knew that the question will always come up where people would say, aren't you just capturing socioeconomic factors? And we wanted to see how income compares if we look at that separately from just looking at our built environment indicator. And then we got satellite images from Google. So Google has an open API. You can get static satellite images for, I think there's a limit of how much you can get, but we got 150,000 of those for the cities. And this is just an example of what an image would look like. So you can see houses, you can see trees, you can see the street. You basically have an idea of what the neighborhood looks like. We used a convolutional neural network, one that was already trained on data from ImageNet. So ImageNet is a very comprehensive database of 1,000 image categories, and it's usually used in computer vision competitions. And so there's a CNN that's already been trained using these images. So we took that CNN and then retrained it with our image data to say, this is what images for high obesity neighborhoods look like, this is what images for low obesity neighborhoods look like, then now go and figure it out with the rest of the images. And then we extract features based on that analysis, and then use that information of those features that have been extracted in a regression model. Obviously, there were too many of them. There were about 4,000, more than 4,000 of features, and so we had to use a method that allows us for dimensionality reduction, so we only ended up with maybe 100 features for some of the cities. So this is the results that we got. So on one side, we have, at the top, we have data on the built environment, and the bottom, we have points of interest data. So we wanted to see how well these 2 different types of data sources would estimate obesity prevalence in these neighborhoods. And what we found was that if we just used the built environment indicator that we're constructing from the satellite images, we had a better estimate of obesity prevalence. So to show you this visually, this is what it looks like for San Antonio. So we have 311 neighborhoods or 311 census tracts. So this is the actual data that we're getting from the CDC, and then this is what our model is estimating. The same thing for Los Angeles, California. Here we have 993 census tracts. So on one side you have the actual data, and then on the other side you have an estimate from a model. And so we're interested to see what the images actually look like that were being captured from these different neighborhoods. And what we found is that in most of the neighborhoods, there were very significant differences in the images. So this is a neighborhood where you have really high obesity prevalence, and this is a neighborhood, the other side is a neighborhood where you have really low obesity prevalence. So this is also, just to show you this again, this is from Memphis, Tennessee. At the top, you have lower obesity prevalence. At the bottom, you have higher obesity prevalence. So we're continuing this work to think about other applications and other ways in which we can use these data sources to improve health in our neighborhoods. So thank you.
Thank you so much for your talk. This is fascinating research. For the first part of your presentation, where you use social media for assessing health medical issues, I was just curious, what was the age range of your demographics? And also, what was the time span? And did you account for people who don't use social media or other factors?
So the data was from 2015 to 2016, so approximately 1 year of data. The age range would probably include, I think Twitter's age limit is 13 to whatever the maximum age is in social media. So we don't actually have the actual age. We did some analysis trying to estimate age and found that it was quite challenging when you're trying to estimate age for very young individuals versus elderly individuals, because they tend to tweet about the same. So they use a lot of emojis, a lot of, So it was quite challenging, but it's something that we're still working on. Yeah. So police stations was actually highly correlated with obesity prevalence, and initially we're confused about that, and then we started talking to social epidemiologists, and they're like, that makes sense. And the reason for that is you have higher police density, police station density in lower socioeconomic neighborhoods, and they also tend to be neighborhoods that have higher obesity prevalence.
One more question.
I like how you differentiate correlation with causality very clearly. So how do you move on from there? How do you go from correlation to actually do inference and get something actually that find causes and to go on an impact?
Yeah, so that's a big challenge in our field in general, because it's really difficult to tell whether if someone is searching for something on Google, whether they're actually sick with that condition or if they're just curious about it. So that's a major challenge. And what we've done with that is to sometimes, like the study I talked about using Yelp data, we actually work with health departments. So if someone is reporting that they have food poisoning, the health department can follow up with them and try to see if it's actually true. So they would get more information about what they've consumed on that day or the last few days, and then gather that information with information that's been submitted by other people, and then they can do an investigation. So in that sense, they can validate that data. For some of these other studies, it's a lot more challenging to actually validate what we're seeing. Thanks.